next and last item on our agenda is a very important one, and I really appreciate that Brad Finegood from Department of Community Health Services is able to be here today with us. He is going to be providing us with a briefing on the recommendations of the Heroin and Prescription Opiate Addiction Task Force. We did have a I think we've had a couple of briefings, the last one being last June. I did attend the press conference, or part of it, last week that was held at Harborview Medical Center. And as I mentioned in our council meeting last week, when we had a resolution on recognizing September as National Recovery Month, that earlier that morning, late the night before, a nephew of my husband and mine overdosed and died, 26 years old. This was in St. Paul, Minnesota, and he'd been in and out of treatment programs for 5 to 6 years. And as I understood later, was using heroin as well as OxyContin and steroids, which probably compounded the situation for him. And so this has really hit home to me personally as a wonderful young man. And so when I was attending not only the last meeting of the task force for a while and then the press conference, I asked both Jeff Dushin and Brad Finegood here if one or both could attend our meeting today. And I know that Brad had to make some changes in his schedule, which I really appreciate. I hope that we do have a lot of viewers watching. You have a PowerPoint
I do.
With you.
I do.
And we have copies. And I hope that some people in the public are watching this. There's been quite a lot of media attention to this with some of the recommendations. So thank you very much for being here, Brad.
Thank you, Council Chair, and thank you, Council members, for having me here today. It's been, this is one of those bodies of work and pieces of work that I wish we didn't have to do. But unfortunately, it's the responsibility of our division and me personally to carry out this body of work. So as you mentioned, I think this is the third sort of briefing this year on the opiate issue. I was here with Dr. Caleb Banta-Green early in the year talking sort of about the prevalence of the issue, talking about the task force that we were going to be implementing at the time. And then I believe Terry Mark, Deputy Director for DCHS, was here in June to give just a brief update. As you mentioned, Council Chair, this epidemic has
not Council Chair.
Oh, I'm sorry. Thank you. I stand corrected. Sorry. This epidemic has reached so many people and so many families and so many different groups of people. As you mentioned, your nephew, that's how old my brother was, 26 years old when he died of a drug overdose. So it really and this changing trend for people to be impacted earlier and earlier in their life is something that we've seen often. So a little bit about the task force. The task force was called together by the King County Executive, the Seattle City Mayor, the Auburn and Renton mayors in March of 2016 in response to the drug trends report of 2015 that showed an all-time high in drug overdose death. At that time, we were tasked with coming up with recommendations in a really short amount of time. We had 6 months, basically, to come up with recommendations, and we were also tasked that if there were implementable solutions during that time, to do whatever we could do that was possible to address the opiate overdose issue. So I have a chart, graphic in front of you, sort of talking, it's more of a problem statement than anything. In the upper, I guess, left-hand corner of the infographic, basically what we're seeing is a trend of people dying, not so much of prescription drug overdoses, like there was in 2009. In 2009, it was basically 3-to-1 prescription drug overdose deaths. In 2014, the trend reversed itself to about 3-to-1 opiate overdose deaths involving heroin and not prescription drugs. One of the really interesting facts is that people who start use of heroin nationally, about 80% of them start with prescription drugs. So they start with prescription drugs, but then they get cut off at a fairly early age. And it's harder and harder to abuse prescription opiates due to formularies. It's no longer can you crush it and cook it like in 2009. In 2012, they changed a lot of that. Moving to the right, we've seen that drug seizures have gone up exponentially from 7% that have tested positive to heroin to 40% in 2015. Locally in King County, from 2000 to 2015, the number of needle exchange in a one-for-one exchange at our needle exchange have gone from 2 million to almost 7 million needles exchanged in our needle exchange in 2015. We've seen it in our publicly funded treatment system. The number of people who who are entering our treatment system for heroin has grown exponentially and is now at about 34%. And we know that young adults are entering treatment for detox at an all-time rate. So 86% of the folks who are under the age of 30 who enter detox in our county are entering for opiates, where it used to be for alcohol.
Jeff, I'm not Jeff.
Not yet. No, I'm just joking.
So a question
Sure.
on the graph with the number of needles exchanged. Do you have any data in terms of how many people were involved here? I see it strictly on needle exchanges, but almost 7 million.
Yeah, I don't have that information in front of me, but I can get that. I believe that information is available to us.
Thank you. Councilmember Lambert.
So I'm going to ask what sounds like a silly question, so I want to preface my question with that. But I have been very concerned about the increase from 2 million needles in the year 2000 to 7 million in the year 2015. And what I'm hearing from the people that clean up garbage is that the garbage is inundated with this stuff. And that they're doing some pretty yucky things, which I do not want to talk about because, one, it's gross, and number two, because I don't want anybody to get any ideas. So having had the opportunity to go to wonderful places like PATH and see that they invent things that help people medically, could we invent a compostable, biodegradable needle so that we can deal with this and not have all of these needles around that are dangerous? I know they've done it with vaccinations. They look like little lollipops. Is anybody doing anything like that yet?
I have not heard anything of the sort. With science and technology today, I would not put anything out of the realm of possibility. It's something that we can definitely talk.
If you talk to somebody at PATH,
Sure.
their R&D lab is just an exciting place.
Yeah.
Somebody let me alone in there for a couple hours. I would be having so much fun. But anyway, I think that that's something we need to do because it's really getting to be scary having that many needles all over.
Yeah, and we know that one of the issues that we're having in the community is people who are using substances, intravenous drugs with needles outdoors and leaving needles around. And so we have done a fair amount of discussion of that in the task force.
And did you come up with anything?
Well,
He'll go over that.
couple of slides away.
Okay.
And do you know, Brad, have any data in terms of these numbers from 2000 and 2015 and an amazing increase, that there's a corresponding increase in the number of users?
Yeah,
Or is it more people are using, or are more likely to exchange needles now, or is it both?
I would think it would be both. With the prevalence of needle exchange services and the relative destigmatization of those services, I think people are more find it more accessible to use the services. We have a couple of needle exchangers around the county, and so we've been able to spread into South County to be able to provide those healthcare services for individuals. I would also say that the number of users has also increased. Opiate prevalence is a really difficult thing to track because we don't know exactly how many people are out there using. We do know that more people are dying. We do know that more people are entering treatment for opiate use disorder, and we know that more people have access to services. We also know that overdose is up, that non-lethal overdose. So every indicator that we have points to a tremendous increase in the number of people that are using.
Thank you.
Of course. A couple of other things is that in this problem statement is that people who are housed can access treatment better. It's not rocket scientist to understand that folks who have stability in their lives can more steadily access treatment and stay with services. We're trying to develop a treatment system that's accessible to everybody, and that's really part of the task force charge. And lastly, medication-assisted treatment saves lives. There's been a number of research articles put out that show that people who are on medication-assisted treatment for opiate use disorder cuts their risk of overdose by half. So if people can get on either buprenorphine treatment or methadone treatment, their risk of overdose gets cut in half.
Do you have any estimate of how many people who have an addiction here know about the treatment that could be available to help save their lives?
Yeah, so we believe that a fair amount of folks know about treatment. People who access needle exchange services get touched by social workers, get touched by staff that make everybody aware of services. Treatment accessibility is a whole nother issue, and that's one of the charges that we've taken up in the task force's treatment on demand. So to be able to provide low barrier treatment to those who need it near where they need it, so that if I need medication-assisted treatment, I shouldn't have to travel, for 4 hours each day on the bus in order to get my daily treatment dose.
And do we have any in-house treatment where people, residential, where they have it for 30 days or 60 days or whatever?
Yeah, there's a whole array of residential treatment services that we have through our department at the county. We're tasked with being able to provide that whole treatment array of services. What we're trying to figure out is, can we provide residential treatment services in addition to medication-assisted treatment? Because for so long, those two treatment modalities were separate, so people in residential treatment would never be able to access medication. But what we know is that if people can get on medication, gain stability in their residence and in their residential treatment setting, then it's going to be a much easier transition when they get out. Okay. So we're ready to move on. Thank you. So we basically came up with three overarching topic areas that we wanted to address. We decided from a really early point in time that we wanted to stay with achievable goals that we could implement and that were really overarching. So we really stayed away from coming up with 67 different recommendations that would take a lifetime to implement that wouldn't necessarily all make significant change. So we really came up with out of our three overarching areas, which are prevention, treatment expansion, and user health services, we came up with 8 primary recommendations. All of these, I just would like to mention that we did within an equity and social justice charge. At the second meeting, we came up with a whole charge for our task force that basically said there should be no recommendations that go forward that aren't looked at through an equity and social justice lens. We know that people who have used drugs and have substance use disorder, and especially opiate use disorder, have been discriminated against, if you will, for a long period of time. And so in order to achieve equitable access and equitable services, we needed to look at this through an equity and social justice lens. So with prevention, when we talk about prevention, we're really talking about preventing inappropriate initiation of opiate use disorder. So we understand that people get prescribed medication, but how can we stop inappropriate prescriptions? how can we stop prescriptions from getting in the wrong hands of folks, is really what we're looking at. Because we know that 80% of new heroin users started with prescription opiates. So the first recommendation that we came up with is just about awareness. One of the things we learned as part of our task force, we had a public meeting in Renton, and 120 people came out. And one of the things that we heard time and time again was that it was about the ability to have conversation, right? And by talking about the problem, being public about the problem, and having conversations, that we start to destigmatize and start to gain awareness. And so how can we increase? So one of the prevention recommendations is about increasing awareness of the possible adverse effects of opiate use, including opiate overdose and opiate use disorder. So people can help those who are in active overdose. People can save a life. This is what it looks like for parents in the house, recognizing the signs. If young people are getting into medication, that type of work. The second recommendation is about promoting promoting safe storage and disposal of medication. And this is a big one. We're working with Public Health King County, who has a drug take-back program that they're implementing. And so really about leveraging existing resources about drug take-back and letting folks know when they get a prescription, whether it's a physician or a pharmacist having a conversation with somebody getting a prescription, about safely locking up the medication and about safely disposing the medication when you don't need it anymore. I once went in for a surgery, doctor prescribed me some medication, some pain medication, some opiates, and he goes, "You're probably not gonna need any of these, but it'll keep you from getting off the couch." Right? And so that conversation stuck with me because basically what he did was inappropriately give me some medication to be left in my medicine cabinet. I have 3 kids, easily accessible. So it's about having those conversations. It's about safe storage and safe disposal. The third recommendation is about working with schools and healthcare providers to improve screening practices so we can prevent and identify opiate use disorder. So it's about early intervention, and rather than waiting until the problem gets to dependence, if you will. So those are the 3 prevention.
Councilmember Lambert?
Thank you. So 3 quick things. I got an email yesterday from a lady who was trying to get Narcan because she has a child that is drug impacted, and said it was a horrible process for her to try and get it. And I thought it was supposed to be really easy. So tell me why it wasn't easy.
I don't know the answer to why it wasn't easy. So Narcan availability should be ideally at almost at any pharmacy. There's a number of pharmacies that have what's called a standing order. So basically a doctor writes a prescription to the pharmacist to be able to prescribe it to anybody who comes in the door. So there is a list, excuse me, at stopoverdose.org.
Stopoverdose.org, that's what I need.
Yep, stopoverdose.org. And that is where there's a list of every single pharmacy in the state that has a standing order. So anybody can walk in. I walked into Kelly Ross Pharmacy up at the Poly Clinic and bought a naloxone kit. And so it should be, it is, and it should be really that easy. It's probably just a matter of people knowing the right place to go. But we can work on, through our website, making that even easier to link the information.
Excellent. And then I went to a conference, and they were talking about this issue, and they said there are 2 things that have changed. One, the doctors are not being held accountable for how many prescriptions they're writing. So, one person in the group said that she'd broken her arm, and they gave her 100 pills. You don't need 100 pills for a broken arm. So that until we as providers, this was county people from across the state, actually it was across the country, I was at the national convention, said you as providers need to, in your contracts, monitor the number of pills that are being prescribed to your people so that this doesn't happen. So they said, first, we as business people need to stop it. That's the first thing. And the second thing is that the pharmaceutical industry or the doctors changed the faces now that they use for your pain level. And where before they used to say you need to be a 3 or 4 to get pain level medication, now if you're a 1, you get it. And they said that has to exactly go back. So how are we going to do either of those 2 things?
So through our task force, we talked a tremendous amount about prescriber education. There is a tremendous amount of work being done on a national level with President Obama's Comprehensive Addiction and Recovery Act around prescriber education. The Surgeon General was here a couple of 2 months ago, and we spent the whole task force spent time with the Surgeon General, and the Surgeon General is taking it up as this is one of his major missions, is to work with physicians about being part of the answer, not part of the problem. So in a comprehensive level, another conversation that I've had with a number of people is around the utility of the prescription drug monitoring program and how that's being used to monitor physician prescribing activity. That could be something that is looked at in the future.
Well, the task force that spoke, which were national experts, said to us, until you get those two things done, you can forget this is ever going to be solved. So that sounded pretty authoritative to me, that's places to start. Thank you.
And as mentioned with that prescriber monitoring one, that was enacted at the by the state legislature. So the legislature's done quite a bit on this. Yeah.
So our second overarching work group area was around treatment expansion. This was the work group that I chaired, so I can probably talk most eloquently about this work group. So there was really three major recommendations in the treatment expansion. And just to mention, too, that the full 100-page report is available online and on our website if you would like to take some time to read that. It's a little bit. But basically, so the three major recommendations that come out of the treatment expansion work group are: number one, make buprenorphine, and buprenorphine is a medication-assisted treatment that's used to treat opiate addiction. It's not necessarily has to be in a clinic, but a doctor can prescribe it. So make buprenorphine a treatment more accessible and available in the communities where there's greatest need. We know we've looked at some research around equity issues around buprenorphine treatment versus methadone treatment, and we know that communities of color are much less likely to access buprenorphine treatment just because it is so much more difficult to access in certain areas. And so we're working hard to be able to promote access to buprenorphine treatment in multiple types of medical settings. One of the things that we've done is we've started a low barrier medication-assisted treatment buprenorphine access at the Downtown Public Health Needle Exchange. So it's an extremely innovative program, first of its kind, so people can come in, get needle exchange services, and get offered medication right on site. So that's something that we've been able to stand up. The second recommendation is make treatment on demand available for all types of substance use disorders. As you mentioned, the residential treatment, detox treatment, outpatient treatment, we have a limited supply of detox beds available in our county, but that's something that we're working on. Council's made significant investments in the infrastructure of our treatment system, and so we're continuing to try and to search for ways to be able to make treatment on demand available to everybody close to where they live with no barriers. And then the third recommendation is to alleviate artificial barriers that are placed upon opiate treatment programs. One of the RCWs, 71.24.590, is the RCW that governs opiate use disorder programs. And so we're working with the state to craft some language to look at ways that we can make the RCW much more friendly for people to be able to access treatment. Right now, there's a number of limitations that are put upon opiate treatment programs. Makes it difficult to stand opiate treatment programs up. Medication-assisted treatment, methadone clinics have a really hard time being able to stand up. And so what happens is people have to travel an exorbitant distance in order to access medication. And lastly, user health services and overdose prevention. So there's two major recommendations that came out of this group. The first one is about expanding naloxone, and Councilmember, you talked about the ease of access of naloxone. Everybody should be able to access naloxone, and everybody should understand why it's important. It should be discussed when somebody gets an opiate prescription, because not only is somebody who is on heroin at risk of opiates, but somebody who has an opiate prescription is at risk of opiates. So, and then the second one, which has gotten us a lot of conversation, is create at least 2 locations where adult with substance use disorders will have access to on-site services to be able to safely consume opiates or other substances under the supervision of trained healthcare professionals. We have called these sites CHEL sites. That we've called them community health engagement locations, where people can consume substances under a supervised setting, so supervised consumption spaces. We made a conscious effort to call it a community health engagement location because supervised consumption spaces really didn't do justice to what we were trying to do. What we're really trying to do is engage people who have been really reluctant to engage with providers in the past with help. And so if we can engage them in health services, then we can be able to, by allowing them to safely consume substances, then we can possibly engage them in treatment, possibly engage them in health services, keep other negative health outcomes, overdose death, other types of transmittable diseases, other types of health problems from occurring if we can have health engagement locations. There's about 80 to 90 supervised consumption spaces around the world, and they've shown to have really good outcomes in almost every single, they've been researched quite extensively. The closest one is in Vancouver, BC. They've been around for 20 years, and in their 20 years, they've only had 1 death at the facility.
And is it fair to say this is the one that's provoked the most
It is. It is
interest,
more, it's more than fair.
resistance, opposition, whatever?
Yeah, it's more than fair to say that. I mean, it really draws upon a lot of values that we have. And, I can say that myself personally, I can speak to the fact that I was vehemently opposed to this idea when I first heard about it. The more I learned, the more it not only made sense, but it seemed like it was one of the best, most effective interventions that we can employ, because people, I think it's safe to say, one of my colleagues said, if somebody has heroin in their pocket, it's probably safe to say they're going to use it. And so as best as possible, if we can have them use it in a safe and supervised way, and in a way in which we can engage folks in services, I think that's one of our best options. So, Councilmember Lambert, in response to the syringe issue that you were talking about earlier, one of the anecdotal stories that came out of Berlin was they had a community park that was filled with people who were using substances in an open air market via needles, and there were needles everywhere. It was in really bad shape, and so Berlin decided to stand up a supervised consumption space just blocks away. And so what ended up happening was everybody came indoors to use in a safe and secure environment. And what ended up happening was everybody ended up vacating the park for use. And so all of a sudden there were no more dirty needles in the park, and families started using the park again, and it was safe to use the park. And so we know that if you can locate supervised consumption spaces close to where people are at, they'll use the services. We know that from the needle exchange survey too. If you have one in the whole county, it's not going to have the impact necessarily that you want. The more diffuse you can make it, the less community impact that you'll have, and the more public health impact that you'll have.
And what are there any community health engagement locations in the country? None, so we would have the first.
Correct.
And what is needed to get this through? Is an ordinance needed, a new one, or what? So
that's a really complicated question that we're trying to figure out a pathway forward to right now. There's a lot of conversations taking place and a lot of community groups stepping forward. We're having, conversations need to be at the federal level about this. But there's a lot of interest. Surprisingly enough, I haven't gotten too much hate mail about this, and I've gotten a lot of response of many people who are extremely supportive of this idea. I think it's going to take community engagement, some resources, some funding, but I think that I'm hoping that there's a path forward. At this point, they're purely recommendations, and so I'm hoping that we believe that if all 8 of these recommendations come forward, then we can make a significant impact on the opiate issue in the county.
Councilmember Lambert.
Thank you. Well, I'd be very interested in seeing your 80 to 90 places in their research offline.
Sure.
I did go to the hearing at the UW when the director of the BC facility spoke, so I wasn't terribly impressed. And I was disappointed because I was hoping I would be very impressed. I used to live near a methadone clinic, and I was reading in the paper yesterday some things about citing this potential facility. And the things I was reading in the paper brought me back 30 years, actually more than 30 years, saying, oh my gosh, this is exactly what we as a neighborhood experienced. So what we did in the neighborhood was we worked with the facility to look at some time limits so that when people came, they weren't going to say, this is my home away from home every day for the next 75 years. But if I'm going to be here, I've got a whatever. And it depended on what else was wrong with your life, because there's usually multiple things. But in your situation, we're going to try to get you to this place where you're reducing your consumption in 6 months or a year or whatever. But there was a standard by which you had to do this. You couldn't just be coming, shooting up, and hanging out. So I think having some kind of parameters where people know, I'm coming here as serious business. I'm taking this seriously. If they're not taking it seriously, it isn't doing them any good. We have to have people willing to make the change, because it's not easy. And anybody that's ever been on a diet and eaten a cookie at midnight that they weren't supposed to eat knows the temptations are really tough. And so it's not easy, and it's not you're a bad person. It's the temptations or addictions or whatever are tough. But we have to have something that protects the neighborhood. And unless people are serious and they're going to we're going to hold them accountable, and that they're not going to be hanging out in the neighborhood and doing some of the things that I see across the street. It's not fair to put that in a residential neighborhood. So, thank you.
Councilmember Gossett.
Thank you, Madam Chair. How do I know when I am addicted?
You know.
Yeah, so that's a really good
Not
question. There's
necessarily.
there's clinical criteria, and just terminology. We're one of the premises that we used for the task force is we tried to move away from like the like addict mentality and terminologies like that, and understand addiction as a crime, as a public health condition, right?
Health issue.
Yeah, and because really the addiction becomes a brain disorder is what ends up happening. There's a number of clinical criteria. I think to each individual person, it's something that they have to like self-identify with. Is this, is this a substance that I feel a compulsion to have? Right? Is this something where it's changed my life, where I'm doing things now that I didn't do before in order to obtain the substance or under the influence of a substance? Those are some clinical criteria and some sort of questions that somebody can ask themselves whether or not they feel that they would want to look at getting help.
Okay.
Councilmember Upthegrove.
Thank you, Madam Chair. And I guess this is more of a discussion than a question. I was going to reflect on some of the comments that our Councilmember Lambert made and some of the challenges we've seen with citing. I can't overstate the challenges of citing these kinds of facilities. Excuse me. There's a proposal in my hometown of Des Moines to place both mental health inpatient treatment and substance abuse treatment, including methadone, and the level of community outrage. And some of it's nasty. The slogan was kids before addicts. It really pitted people who were sick against kids. A lot of it was based, not all, but a lot was based on misinformation. During all that, one of the things I did is looked at the data and research around methadone clinics in particular, and as did the local city. I think their judicial branch actually pulled together studies from around the country. And I don't think people believe this, but what the data showed was there was not a statistically significant increase in crime in the neighborhoods surrounding the treatment facilities. And anecdotally, what often was, in a community like this one, is it sounds hard to believe, but it can, quote unquote, this is a bit of a disparaging term, but quote unquote, clean up a neighborhood. When we have folks who are struggling with addiction, who are sleeping in the doorway of the library, who are leaving their needles in the park, who are creating conflict with neighbors because of their behavior and their conduct, because of their addictions. When treatment was made accessible and local, those community conflicts were reduced. So there's a certain irony there, in that there's an inherent gut level neighborhood objection. Yet when you look historically and statistically, you kind of see those same concerns those neighbors have actually can be addressed by providing the treatment services there. And just the neighborhood opposition to citing things in general has gotten tougher. Over the last few days, I've seen the county's looking at putting a homeless shelter in White Center. We desperately need shelters. Neighborhood opposition. We heard today on the comp plan. It's the point where a proposal to put 16 units of senior housing in a neighborhood. It's going to destroy the character of the neighborhood. You know, the ability now to locate public services in a community is so difficult to navigate the politics and the local government and local government officials who respond to that political pressure, who have oversee the land use and permitting. And so I wish you luck, I guess. It's a long way of saying, I just wanted to reflect on that, having gone through that with our
Thank you.
Our community.
And I'd like to comment too. You mentioned, Brad, I believe that 26, is about an average age, did you say, or common age of young people?
Yeah, under the age of 30.
Under the age of 30. So addiction and all that goes with it can take many forms and with many different people. My mother died 2.5 years ago at the age of 97, and she became addicted clearly to OxyContin and fentanyl because of horrible, horrible pain from arthritis and other things. And she ended up in a skilled nursing home only on Tylenol. And we were able to finally find a physician who was able to successfully wean her off hugely high amounts that she was taking of these two opioids. And the physician earlier, good-hearted, but she was in such horrible pain and would have these terrible pain episodes and scream at the retirement home where she lived, and then in the assisted living community, just scream because she was in so much pain. So the dosage just kept getting increased. And she overdosed at one point because she forgot to change her fentanyl patch, which had to be changed every 3 days. It was just tragic. And we were finally, realized what was happening. And it took probably 2 or 3 years to get her to the point where she no longer took any opioid.
Yeah, we know that all age ranges are expanding as far as overdose deaths, but we've really seen a significant increase in older adults, and for that reason exactly, the amount of pain that people are in, and it's easy for doctors to prescribe opiate medication. Ironic is that it's so easy for doctors to prescribe thousands of opiate pills, but the one treatment medication that they can prescribe, buprenorphine, they have to jump through hoops on top of hoops on top of hoops to be able to prescribe. I mean, it's so ironic. It's amazing, And to Councilmember Up the Grove, what you were discussing is exactly right. It's about if you provide treatment for individuals, they'll recover. If you don't provide treatment for individuals, they're going to suffer where they're at. And that's the sad part. And so what we're trying to do is really the foundation behind our task force is to be able to provide those treatment resources for the really difficult people to engage, and for some of the community issues like public needles. We believe that sites like Chell sites will help with that. But time will tell. There's an expansive evaluation component to it also.
One more thing, and then I think we're going to wrap this up. It's really fascinating, and appreciate your being here. I know several years ago, and I'm not sure if it's still happening, but our U.S. Attorney for Western Washington at the time, Jenny Durkin, was engaged in an enormous effort to crack down on some of the pain clinics around the state owned by physicians who seemed to be prescribing. And I don't know what's going on with that now. Are you aware of?
Well, we just had a huge crackdown on Seattle Pain Clinic, which had thousands of people on Medicaid receiving hundreds and thousands of opiate prescriptions. And they had 6 different locations across the state. And so it left this huge glut of people needing treatment. The problem is that a doctor who's out there prescribing inappropriately, to cut somebody off just leaves thousands of people out there in active addiction. And, there's probably an underlying issue. And so we can't, if there's an underlying pain issue, we can't treat those folks with methadone in medication-assisted treatment clinics. It's only for opiate use disorder. So it creates this huge, huge problem in our community. But, that's another reason to continue using the tools, like you were saying, the prescription drug monitoring program and other tools at our disposal.
And we had looked at this quite a few years ago in the legislature, and it's very hard to get changes because people want the prescriptions and they see the advertisements on television or here on radio or in magazines or the newspapers, continually about try this medication. It will really help you with your pain. And then they go in and demand of their doctors, their healthcare providers.
Well, and things like fentanyl, which has an extremely high dosage rate, are things that we're struggling with in the community right now.
Well, thank you very much for visiting with us, providing the briefing. I'm sorry that interfered with your schedule.
It was a pleasure to be here
But
today.
I think it's very important to get this information out. So thank you very much.
Thank you all.
Brad.
It's an honor. Thank you.